Hello and welcome at PCR London Valves. My name is Philipp Lurz from Mainz and I'm here with Saibal from Los Angeles. And we are here to discuss whether closure of iatrogenic atrial septal defect is a necessary procedure. Saibal, what is an iatrogenic atrial septal defect?
So, Philipp, as you know, there are several transseptal procedures being done now, and it's become like exponentially increasing. And when you do this procedure, you have to get access into the left atrium, and you create a hole in the intra-atrial septum. That intra-atrial septal hole doesn't close right away, and that is called an iatrogenic atrial septal defect.
So we probably have to prepare ourselves that we see them more often, because we use bigger sheaths across the septum, and the bigger the hole is, I guess the higher the likelihood is that those holes won't close off. Is that a fair assumption?
That's a fair assumption. That, as you said nicely, that there's an increase in number of procedures. They're getting more and more complex. So the sheath size that has to go across the septum is becoming larger, and therefore there leads a larger gap and a lower chance of it actually completely closing off. The small holes, 3-4 millimeters, close up by themselves.
What's the clinical problem of these ASDs?
So, just like congenital heart disease, if you have a significant hole, septum, we usually say 8 millimeters or 10 millimeters more, there's shunting of blood from the left side to the right side, leading to right atrial and right ventricular volume overload, and finally heart failure and pulmonary hypertension. Also, if you have underlying pulmonary vascular disease or pulmonary hypertension, where the right atrial pressure is high, if you have a big hole, you can actually shunt right to left and cause hypoxia. So therefore, a significant shunt is when you have a significant shunting either left to right or right to left.
Here it becomes a little bit complex because there's some scenarios where we think it's good to have an ASD, and then there's some scenarios where we have to close the ASD. How can we decide what to do?
So, putting it very simple, there are three categories of an iatrogenic ASD. One is very small.
Yeah.
So those you don't really worry about, because even you've shown your data with your study that actually whether you closed it or not didn't make a difference. The other extreme is when you have a large hole or you actually tear the septum, where you cause compromise, hemodynamic compromise, left-right shunting with right heart failure. Those have to be closed. And then there is a group of patients where the shunt size is just enough to actually decompress the left atrium, yet not cause a significant left-right shunt. And that may be beneficial in some patients in heart failure where the left atrial pressure is elevated.
So that means that in some patients, if you close the ASD, you increase filling pressures on the left side, which could also cause
a problem,
deterioration of the situation. Right. Test balloon occlusion, is that of any help?
Well, your colleagues have actually shown it that in certain patients where they've actually caused a hole, the patients didn't do so well, and then when they occluded the hole and they measured the left atrial pressures, when they get grossly elevated, it probably is a sign that you should not close it, and it actually may be having a beneficial effect. So we think that there are certain subset of patients where the iatrogenic ASD is a therapeutic procedure. The other two conditions, the small ones are probably inconsequential. Yeah. The large ones are consequential and bad, but a small defect in the right patient may be therapeutic.
And how would you close these ASDs? Once the decision is made that it's probably beneficial to close it.
So most of us know we close ASDs with various types of devices which are available. You have the Occlutech device, you have the Amplatzer device, and then you have the Gore septal occluder. What I don't like in the Amplatzer and the Gore Occlutech is it's a nitinol mesh, and it's quite metallic, and so therefore regaining access through that device might be challenging, though you can puncture the septum around it. On the other hand, the Gore septal occluder is made of Gore-Tex with a very small metal frame. So you have more fabric, and therefore you can actually get access more easier. In addition, there are new devices which are in development, and one of them is called the AtHeart device, which is a Dacron patch, and it's got a polymer framework. And the polymer framework is going to dissolve over 3 years. So you'll be left with only a Dacron patch, which will easily allow access into the left atrium. And we hope this will be the future.
So whatever you do, you should think about whether it's needed to go back to the left atrium and how that could be then done.
I think you should not always have an avenue or access to the left atrium, because there's so many new procedures coming up.
Agreed. Okay, very good. So iatrogenic atrial septal defects, an emerging topic. We will see more and more patients. In some, this causes right heart volume overload. Then the defect should be closed, but always watch out not to increase left-sided filling pressures, maybe test balloon, but overall thorough understanding of the pathophysiology is important. Thank you.